Oh, yeah, of course.
Yeah, well, of course, you're hiding
Amber, are
behind
you
masks,
good with that?
Charlotte.
I-
Yeah,
Okay.
nice.
I don't know where it records. I don't really know how this works. I've never recorded one, but I'm recording it.
Okay.
That's fine.
That's good.
Okay.
And so again, I've never worked in the ED, and I know that some patients get that first swab when they are in the ED, kind of waiting to determine where they're going to go and all of that.
Mhm.
I have heard some ED nurses mention that sometimes people, even in the waiting areas, kind of get labs drawn and even IV started at times. Is
Yep.
it possible when people are like walking in the door to kind of have like oh my gosh, this cat. We can kind of have like almost an assembly line of
Yeah.
people, sorry, Sunny, to like to kind of take that swab and kind of get it going. And if they, are admitted, great. If they're not admitted, then those things can get run and they can kind of be informed of that through my chart. But I mean, again, I'm sure this has already been brought up.
No, part of that rationale, and again, feel free to jump in here, Chara or Augie, is that only about 25% of the patients actually get admitted to the hospital. So 75% of them don't, and most of them are not presenting with COVID symptoms. And so one of the other challenges through the majority of our response, not currently, but majority, has been the supply of tests and reagents for the testing, and reserving those for the situations where you really need to know if that patient is positive versus testing everybody.
Sure.
So it's
What about the Binax test? Is that not appropriate for the patients?
it's not
We're
approved.
so good.
Yeah.
So Binax is only, technically, Binax is only approved for symptomatic patients. Now, that being said, we got permission from the main CDC to use Binax for serial testing. So there's a high false negativity rate with Binax if you don't use it for symptomatic patients. However, you diminish that rate by using it more often. So that's why we use Binax testing, because we're doing serial testing more often. That tends to increase the accuracy. So, but it isn't approved for asymptomatic patients. But that's an excellent question. Again, it makes sense that you folks are asking these questions, and that's why it's helpful for me to be able to directly, talk about the science. There are tests, by the way, which are coming out, which we're hoping may be more serviceable in that regard. We have used, for instance, at our Surgery centers. And we were going to use them at our Surgery centers, but our lab is very, very strict about making sure that our tests come into a certain confidence interval. That's why we don't use Binax routinely for patients.
And then this is the next question. Why are we not waiting at least 72 hours with the highest precautions and 2 negative COVID tests, and then before we remove precautions? Many patients testing negatively, then testing positively a few days later.
Yeah, Char, do you want to take that?
Yeah, I'm thinking it goes back to probably the bottleneck. So if we have patients who are on a unit and they're on, airborne contact precaution, it would essentially be a PUI COVID unit. But they're not PUIs or COVID, because we're doing administrative tests on everybody. So we do the administrative test just to try to pick up these people who may be asymptomatic. They don't know they have COVID yet, or maybe they're pre-symptomatic. And then that's also why we test them after admission. So we wait a few days and then retest everybody. So again, if we do have that false negative, then again, we're picking them up a few days later if they're prematurely negative, I guess, if they're not quite symptomatic. And
the rate of that is low. We've had a very low. Now, again, every time it happens, it causes a flurry.
Yeah.
But the rate of these patients that are coming in that test negative is low. So even administrative tests. In fact, there are some people in the system that wonder whether we should even be doing those We are going to continue if I have anything to say about it. But remember, we didn't even have these tests in the very beginning. Now we have them, and we've actually expanded testing to 72 hours more and more to try to keep staff safe. So that's and it's an excellent question. I get it.
And then-
You're not alone. Other people ask this of their hospitals. We just wouldn't be able to get anybody in. That's the problem.
But we also put preventative measures in place. So that's why we're all
Right.
masking. That's why we
Right.
said, face protection for all interactions with patients. That's why we really try to ask people to try to get your patients to mask when you go into the room. If they have a roommate, pull the curtain. Certainly if there's any aerosol generating procedure happening, that's when you put on your full, N95 or PAP or whatever protection you need for an aerosol generating procedure. So there's other things in between those two tests to help prevent the spread, to help prevent those exposures.
Yeah, in all of our outbreaks, virtually all of them can be traced, although I can't say that recently. The R7 outbreak looks like it was probably patient-driven.
Actually, all of these,
Yeah.
they've started with the patients and
And
roommates.
it's almost always breaches in PPE. And so, some of our outbreaks have also involved, staff break rooms and things like that, which we are much better about. So that's why we really, the best that we can do, and Shar, thank you for underscoring the fact that it's not just testing that we use, it's PPE, so-called universal PPE. Now, I know sometimes patients present problems. I know visitors may present problems. We get it, which is why we've tried to limit visitors. We try to limit traffic on the units. But you can't, people are going to break through. It's the fact of this pandemic.
So I just want to clarify that in these outbreaks, you have been able to find out through tracing that some of it has been a breach in PPE, people not using
Yeah.
eye protection or some.
People coming to work sick. We've had that. That's not an uncommon issue that, people do come into work sick. We've had, in the early stages, we had people that got infected because the patient wasn't masked. And even though the healthcare worker was masked, they might not have used the eye protection we recommended. So, and again, people congregate. It's a small hospital. Nobody's trying to point fingers. We're just saying, if you ask the employee health people, it's very common for there to be breaches in our safety protocols. I come to the hospital every day, except usually Fridays, and social distancing is tough. In some areas of the hospital, it's tough. So that's why we've reduced meetings. We try to tell people, please don't cluster during rounds. So those are, and that's what other hospitals are doing around the country.
So the next question is, why are staff members who are exposed by a patient, Amber has been exposed, I think 2 times, right?
Well, 3 now.
Three now. Why are they not required to get tested? But then when there's an outbreak unit, serial testing is required.
So that's an important, go ahead.
Oh, I'm sorry. I was going to say that I guess there's 2 types of exposures, or what I consider exposure. So you've got your bona fide exposure. You had an exposure to a known positive, let's say patient or another staff member. So what happens is when our department gets all those positives, we initiate that contact investigation. So if let's say it's a patient, we're looking in the chart to see who took care of that patient in their infectious period. So it's either 2 days before their test, if they're, let's say, asymptomatic, or if they're symptomatic, 2 days before their symptoms began. So we look at that and we say, okay, we can see that patient was on this unit, rehab took care of them, they had an interpreter. So we send it to a wide group and say, okay, your staff likely had exposure to this patient. Please send those names to employee health for triage and next steps. And I think employee health's triage, and I can't say it verbatim, I don't know exactly off the top of my head, but it has certainly evolved over time. So, they're gonna ask you a million questions about risk of exposure. Were you with that patient for how long? Were they masked? Were you masked? Were you wearing eye protection? Did you do any high-risk procedures, et cetera? And then make recommendations based on that. So sometimes there may not be a need for a test. Sometimes there may not be a need for anything beyond. You're doing your normal screening as you do every day. Or sometimes they'll say, okay, you need to quarantine and get tested. So it really does depend. And I think now they've also added the vaccination. So if people are vaccinated or not, and if they are, where are they in their vaccination status? So that adds another layer.
Yeah,
other
the vaccine is a very important issue, and fortunately some units have a high rate of vaccination. Some units are not quite there yet, and it's complicated. But we right now the CDC has lightened up on some of their quarantine measures in the community for vaccinees. They have not yet lightened up their requirements for quarantining in the healthcare setting. Largely because, we just don't know about, but we do know that we've had some people who have had 2 doses of the vaccine who have still come down with COVID. How transmissible it is, we're still studying those issues, but we get that question a lot. Gee, why if I'm vaccinated, do I have to mask? We get this a lot from healthcare workers. So that's the answer to that.
Hey, Augie,
So
for the serial testing in an outbreak unit, is that because you have transmission going patient to patient, patient to staff, staff to patient? Is that what you're trying to drill down?
Yeah, that's a CDC recommendation.
Okay.
To tell you, because take a look at some of our units, our cardiac surgery unit, our R7 outbreak. These are critical units. I mean, we are the only hospital in the state that can take care of these folks. And otherwise, we're sending some of these people out of state. It's dangerous to delay some of these procedures because people have, unstable angina, blah, 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 whatever. We have to open these units as quickly as possible. So the state has allowed us to use Binax testing as a way of sort of giving us a little layer of assurance that employees may not be coming in positive. And again, the Binax test is definitely not as good as PCR. So we do confirm any positive Binax with PCR. And we have chosen to regularly test people with PCR because we think it's more reliable. So that's the reason for that. I hope I answered your question, Joy.
So I just want to make sure that we're answering Amber and the others, because I know I've had a
Sure.
lot of conversations with different people on this one, the difference between an exposure and an outbreak. So with the outbreak, you're really drilling down and trying to break that chain of transmission, right? To stop that. With the
Yeah.
exposure, you're going through a contact assessment, which may or may not reveal a high risk exposure. If it's
Yeah.
not a high risk exposure, you don't necessarily need testing in those
Right.
situations. Is that accurate?
Yes, that's right.
And what we say in our department is for like an outbreak, serial testing first, you want to determine who has it and they don't know it yet. They're
Yeah.
asymptomatic, they're not they're not sick. That's the first part of it. The second part is, who is it being spread to? Have we spread it to any other patients or other staff? So that's the rationale for the serial ongoing testing. And
I just would like to add, so 2 things. So at one point earlier on in COVID, I was exposed, and it was not an in-hospital exposure. And so the CDC, based on the interview, I was far enough away, I did not need to be tested. So I think that shows Maine Med is consistent with what the CDC is recommending, because they're the contact tracing people, are the ones that called me. But I'm wondering, Amber, would you prefer, did you ask the question because you would have preferred to have been set up with a test when you were exposed? And then my second question for you, Amber, is when you were at Brigham Women Faulkner, did they test people that were exposed regardless of the level?
So my experience with Faulkner is I actually never got COVID tested until I came to Maine. Um, I I never had the opportunity or was asked to, regardless of exposure, and I certainly was. Um, and honestly, when employee health called me about the 2 exposures with the patients, um, one of them was someone who tested negative and then tested positive and had precautions removed, and then the second one was they'd been admitted and the administrative swab wasn't collected until a few days after, and unfortunately ended up being positive. Um, they never said I couldn't get tested. They just said it
Right.
wasn't recommended. So for both of those times, I still went and got a
Good.
test.
Good.
Um,
We've
my-
taken this,
Yeah.
Amber, I'm glad you made the point. And by the way, I talked to the people down at Partners. I know the hospital epidemiologist there, as well as the infection preventionist. So I kind of know their policies. As you know, they went through testing every person in the hospital, which we did. I don't know whether you were here, Amber, when we tested everybody. We wanted to see what our incidence was. And I talked to the folks down at Mass General because they did that when they had an outbreak at one of their hospitals. You probably heard about it, where they were doing so great. They were bragging about their PPE. They published an article. A week after they published the article, they had an outbreak. But you make the good point. We do not, if an employee is really worried, we have not denied testing. So I think that's an important point.
Yeah, that's something I've appreciated.
We don't want anybody stressed. I'm the only one who's stressed.
You were saying something, Amber, really quick. Did you want to finish what you were saying?
No, and I that's just something I've appreciated, especially because, and granted, it's later on in the pandemic, and I feel like things are a little more sorted out and supplies are there when earlier on they weren't. So it's nothing against my previous facility. It's more just the opportunity never kind of presented itself. And I know that that's something that was, I don't know how Maine Med did it since the start, because I haven't been here since the start of it. But it was something that was kind of surprising, I know, to like my family members or even people at Maine Med, where they were like, oh, well, you were in Massachusetts. Like, how many times have you gotten swabbed? And I was like, I've never gotten tested before until I came to Maine and, quarantined and did all of that to start working at Maine Med. So, yeah, that's really all.
We also have a little different situation on some of our floors, which I'm sure all of you are aware. One of the problems that we have in this older facility is that we do have a fair number of semi-private rooms. And we know that that's a problem. And certainly, my goodness, we try to do our best. I mean, I've had conversations with higher ups at the federal CDC about this. And so semi-privates present a problem. And as you know, before this outbreak, our census was through the roof. People want to come to Maine Medical Center. We have a great nursing and medical staff. We do things pretty doggone well here. We're not perfect, but we do things pretty well. And so our rooms are full. And semi-privates do present a different problem. And that's just to keep that in the back of your mind when you see how we manage our outbreaks here.
Okay, so then another question is, how long is serial testing required of float staff, specifically in regard to R5?
I think we had talked about it last time, Shar, and it was with about 14 days.
Yeah, so an outbreak, if it's declared an outbreak, it lasts 14 days from the last positive. So that's an incubation period for COVID. So like for R5, their last positive was, I think, 2 days ago. So that means hopefully that's the last one. And so we'll go until the 24th.
And that's the
As far as-
CDC. Yeah, the
as far as
CDC tells us to
floats.
do that.
As far as
So-
folks who are not continuously exposed to R5.
Yeah, that's a good
2 weeks
question.
from the first test, I think, Amber, is what we had said. I don't know if it was Shar or Gwen thinking about it.
So I'm trying to think here. So ours, I know for R7, like for their providers, so they had two negative PCRs, so 2 rounds, negative PCRs. And if they did not continue to go up to the unit to take care of patients, they dropped off the testing. And of course, they were not Binaxed if they did not go up to the unit. So
Yeah, just again, just to clarify, and I'm sorry for interrupting so often. Valerie, you've been so polite to me. But a couple of things. The length of an outbreak by CDC definition is, as Shar said, 14 days from the last positive test, or at that, from the last patient that was positive on that unit. Now, that doesn't mean that we can't open the unit, okay? So there's a technical definition that the CDC wants us to continue to monitor, and then there's the practical definition, and we talk to them almost every day. We have to update the main CDC on what we are doing. Now, the main CDC trusts us tremendously because, and you can talk to them, they will tell you that they have been very pleased with the way we manage our outbreaks because we're pretty aggressive. And so they've had good experience with us and they work very well with us. I mean, Steve Sears, who is the person in charge of all of this, is on the phone to myself or Shar or Gwen and myself on a regular basis. And so they sort of call the shots in terms of how long we test, just so that you know, this isn't something we make up.
And then there's this question, which I think other people would want to know this for sure. Why aren't both tests, PCR and Binax, available 24/7 if they are required?
Oh, you mean that people get tested 24/7?
Yeah.
Is that what you?
So we will find out, for instance, we'll find out at 2:30 in the afternoon that there's a unit that's an outbreak unit, and then we're scrambling to figure out which floats have been
Right, yeah.
that. And then we tell them that it is required that you get tested. But then they're a night shift person or whatever the schedule,
Right.
it's challenging because it goes from 7 to 3, and then some of the days it's only from 7 to noon. I think I know the answer is probably the availability of staff
Yes.
to testing. But has there ever been a thought to offer it?
Oh, yeah. We'd love to offer it. We'd like to offer it all the time. We can't. We don't have the staff. And so the other thing is, well, you say, well, that's okay. We've got nurses, they can do it on each other, right? That comes up. You can't, because that's a HIPAA thing. So you really, technically, now I know we all share because we are all friends and we share. But technically, we're not supervisors. We're going to be doing this. They can't, because an employee does not have to reveal their test status or their vaccine status to a supervisor. It's a HIPAA issue. So that's why we can't have supervisors, for instance, doing it on the night shift. It has to be certain designated folks. Does that answer that question? You're right, Valerie. That's the question. That's the answer. You're correct. We don't have available staff. And by the way, I have to tell you, the people that run this, it's amazing how they get people to come in and do the best that they can. It really is.
And we have been, just in case you missed out on it, Amber, we have been paying people for for an hour to come in to get tested. So hopefully you have been when you come in, just because that it's hard.
But,
The check's in the mail, Amber.
is there a way, and I'm sure there's training that has to go along with it, but is there a way that, how floats kind of sign up for rounding shifts, that maybe floats can also sign up for shifts to swab people overnight so that it is more accessible to night shifters, like before coming into work or whatever the case is? I don't know how to work.
That's out of my wheel.
That's something I can ask. Catherine Cope has been the executive lead on the testing plans, but I'd be happy to run that question by her. Okay.
Okay, and then, so I think I know the answer to the question two, this next one. Why are nurses with positive family members not required to test or quarantine and are allowed to come to work without any additional precautions? So I'm pretty sure I know the answer and that it's not totally accurate.
We
but-
actually have I can't say who, but we do have staff that have positive family members that are not allowed to come to work. And in fact, I've had people complain because their kids are allowed to go back to school before they're allowed to come back to work. I've had multiple staff from all levels be put out because someone in their home is positive. I don't know if it's a family member that doesn't live with you. I don't think it's the same. I think it depends on the level of exposure, but that's what I'll let everyone else talk.
I think that might be best answered by employee health, because if we
Yeah, they have
fail,
their own
yeah. If we fail
protocols.
our,
They base their protocols, by the way, on CDC recommendations. So the employee health unit, and by the way, that's a main health system level. Those guidelines are main health system level. But it's interesting, household contacts, they say that we used to consider that one of the highest risks. It's interesting, actually. It's not a lot of we've actually had quite a few household contact people who have the other members of their households haven't gotten it. So you never say never, because obviously that could happen, but it doesn't seem to be as common as people fear. But that's neither here nor there. It's an employee health issue.
So we have definitely had, just to kind of restate what Megan said, I can think of 3 people right off the top of my head, 3 floats, maybe 4, that have been out for at least 2 weeks because they had a family member that was positive. And I don't know what their status was because they're out and I don't know, you know what I mean?
Yeah, because employee health they grill these folks. So for instance, sometimes we can actually separate the family members. And we have tested family members, just so that you know. For instance, if there's a critical person, we've had an issue with a few critical physicians who might be going in to do surgery, and they've had a family member, not just surgeons, but other critical physicians who have had a positive family member, and we have insisted that they be tested on a regular basis. And again, it depends upon the service and the level of exposure. So it's a little more, it's somewhat more complicated, but I think that's the best answer I can give you right now. Trying to skirt the issue, I just think it's employee health policy. And by the way, if you want, you can go and look at the CDC guidelines. They're very easy to go to. You go to CDC and then you go to healthcare provider, and then you could actually look at recommendations for healthcare workers returning to work and assessing the risk of exposure. So if you're interested, sometimes that's helpful.
Yeah. And that question for me came from, I was floated to one floor and one nurse was walking around being like, yeah, my roommate's positive and I'm here. And I was like, what? And granted, I don't know the whole scenario, but I just was like, well, that just kind of sounds odd because, the other people that I had heard of that had positive family members or whomever, were either told to stay home or whatever the process was. So I just kind of didn't know what the standard was for when someone does have an exposure outside of main health and, someone who they do live with, and makes sense. It's an employee health issue and they're probably kind of following that.
Yeah, maybe they might like work opposite shifts of each other. One's always in the room and the other one's sleeping. And so even though it seems like it should be like a straight and across, I bet when they grilled into it, it was like the risk was minimal.
Yeah, I actually did ask this a couple of times, have conversations on this with Sue Guerin. And, every case that I put in front of her, there was a reason of why the decision was made. And that's just not something that we all hear in the moment. But she was able to demonstrate that, at least in the cases that I referred to her. So that's really all the information I can say on that.
So Joy brings up this point. What you may not know is that every time a nurse or other kind of provider calls out, that's a strain. And so at the height of the pandemic, it was very, very difficult to staff things. Fortunately, the hospital census went down. But we on our morning HICS meetings, we actually go through the positive employees. Why was that? How many employees were sent home? Why? How's that going to impact staffing on our floors? Because that's important. And so you're again, these are great questions.
Yeah.
I'm gonna let Amber ask the next question just because she wrote these kind of quickly after a staff meeting. So some of them, I think she probably would like to rephrase.
Yeah. So the next one is more related to visitors, and if we're able to kind of start, I guess I'm more curious about what are the discussions of allowing visitors back into the
Yeah, good.
hospital, just for lots of reasons, but also to do that safely. Are we able to maybe test them as they come in? Is it, are we able to kind of keep it more of a by exception sort of thing? I know with like CMO patients and that sort of stuff, we're allowing some visitors in, but if we kind of open that up a little more, people who have been there for months and months and months and months, and kind of would really help them, are we able to kind of schedule their visitors and have maybe a Binax testing done when they come in, which you kind of answered that earlier, but that's
Spoken like a true nurse. A true nurse would be caring about their patients and the visitation. Thank you. So just to let you know, Joy is probably going to say this, visitation policy we're going to be having some changes with expanding visitor hours. Again, that comes from the Maine Health System, Amber. And we understand, Joy will probably correct me if I get it wrong, but we do understand they're going to be broadening visiting hours next week. Joy, did I get that right?
Yes, next Wednesday, I believe, is what I heard. It's going to resume based on what we were doing back in November. So one person, 3 hours, 3 hour visiting period a day. As long as the units are able to support appropriate distancing and everyone's complying with the mask wearing. Changes to visiting, there's no changes to visiting for the intensive care unit of pediatrics or OB. So, that will all continue, but they are planning to resume that next week. There's been a lot of pressure statewide on this issue.
And remember, we also at the same time are trying to reduce congestion in the hospital. Once we put things up to visitors, you know how hard it is to get in or to get out when visitors during visiting hours.
Yeah.
With those little narrow corridors that we have to go through.
Yeah.
So we have to think about that, and that is as we speak, that is being discussed today.
Right.
About
So
how
they
we're
have to
gonna-
be screened. We're not able to mandate testing.
Yeah, we can't
But
test
they
them.
have to be screened. They have to be able to comply with leaving their mask on. If they don't, they can be asked to leave or removed if necessary. So, again, if the room, I think of the Richards buildings all the time, we all do, they're so tight. And if you have 2 patients, 2 visitors, and then you have nurses and CNA in the room, or the team comes to round, you have to address that density, and it may be you adjust them based on that. It's not an open season that they can come in no matter what. You still have the ability to make the call based on the clinical situation and the risk that is perceived in that area.
Yeah, because you guys will be getting calls, and I'm sure Megan will probably, certainly, the head nurses are going to be able to, and the nurses will be able to advise visitors. You know that better than anyone.
Mm-hmm.
But maybe it's probably not a bad idea to see if you can't get them in for, staggered times during the block of time. I think it's a 3-hour block of time that we're going to have to select for most.
Yeah, and I know that there are areas that are discussing that today, that They
Yes.
can't possibly have all their visitors in a 3-hour period. It would be overwhelming. So they are working through what that looks like on those different areas.
And, you know, most hospitals that I know of around the country, the nurses, the nursing staff will make decisions and help guide visitors about visiting their loved ones. And, you know, I have a family member who's right now out in Chicago visiting someone in the hospital. And they talked with the nursing staff, and the nurses say, yes, you can come in and what have you. Again, I do like what Joyce said, or somebody said about the masking. Please, visitors, people have to mask.
Yeah.
So important for your protection.
So then, and then the next question is, and we've kind of covered some of this, but so R5 was on the brink of an outbreak. And then there were a couple of floats sent there without knowing it was at that level. And there were two positives. So there were two positive people on the floor, but it wasn't yet at the outbreak level. So I think Amber's question is, should people be notified? And I think it's because this was handled differently on CFT6. Am I correct, Amber?
Yeah, and also just it's more so pertaining to floats as well, where I kind of wonder if floats should kind of be pulled back from units that are kind of experiencing a potential outbreak. Where I think one of my colleagues that work on that floor was saying, you know, I think I was sent there Sunday and Monday as of like 2 p.m. it was considered an outbreak unit, and Saturday it kind of started where 2 patients tested positive, and Sunday morning maybe another 2, and you know, where floats are kind of being deployed all over the hospital and in a 3-week shift are going to 3 different floors. You know, is it possible to kind of pull back floats in that scenario to kind of prevent any further spreading? Or I don't know if that I'm making sense, but
You are. And that's a good question. I'm probably going to let Joy and Shar address this, but one of the principles of controlling an outbreak on a unit is to cohort patients and staff. So we try as much as possible to cohort staff. So I don't think that we were sending, well, you could answer this, Shar and Joy. It wasn't the intention to send floats to outbreak units.
I think with this particular instance, I was just looking at the R5 data. We had 1 positive on the 4th and then 1 on the 5th. They weren't related because one was a male, one was a female. So it wasn't like it was a roommate situation. And then, so that, you know, what we do is, so when we see those, we have our own databases and we put those in. So you're right, we keep an eye on them, like, okay, now we've got 2. And then rapidly we had the 2 positives on the 7th, but we didn't, you know, that was later on. So I think this all like basically like, you know, Sunday night into Monday, it was like rapid succession, like, okay, now we've got something going on. I don't know that we would have been able, I'm trying to think though, if there's any, I mean, because it can happen so quickly, like the 2 on CFT6, those, again, that was like a, you know, rapidly Sunday night or into Monday morning. Okay, we've got 2 now. And so I think, you know, just, it's kind of a lot that happens all at once. And by the time you get all the right people together to talk about things and determine what's going to happen, you know, time goes by. But I don't know if we could, I don't know, I could, you know, if anybody has any suggestions, I don't know if we could do anything different. Like, you know, we see 2, okay, but they're not related. There's, you know, it's, you know, 1 could have been like an admin test. These patients were not, you know, suspected of having had COVID.
I fear too, like Amber, maybe you're thinking of some kind of trigger where like we get to a certain point, we like hard stop floats going there. But my fear is like, what if it is 2 patients that are unrelated and that's as far as it gets? But because floats are now not supposed to go there, all kinds of rumors get spread because people talk. So you might have and go, oh yeah, I'm not allowed to float to your unit because the COVID. And then suddenly that unit's like, what do you, I mean, are we in an outbreak? What's going on? And then they feel like they haven't been told the right information.
Right.
Well, I think there, it does raise an interesting issue. I know it happened in one of the outbreaks in one of my units that, you know, it had been sort of emerging for a few days and I knew nothing about it either. And so it is, as Shar described, it's you take this piece of information, you put it with this piece, and then you're kind of building it as it's emerging. But perhaps there's more we could do about situational awareness when the decisions are being made and to the people who are going on that unit in general, that to be aware that we've had a positive case or two. But let's talk about that and see if there's anything we can do to improve in that situation. I'm really not sure if there is. I think that as Sharp also pointed out, you kind of think you're doing the right thing in the moment as it's evolving, but maybe there is something else that we can do. And I think we should look at it and see.
So Amber, just in case you think that you're presenting yourself as whining about this, you're not. We have had complaints from providers who just come and visit the floor and say, why wasn't I told that a positive patient on this floor? And the doctors are sometimes the worst, okay? So you can imagine, we calculated that between R5 and CFT6, there are over 1,000 employees, and many of them don't even read their emails. If we were, for instance, suppose we were to send out emails to let everybody know, R6 is or R5 is a problem. Even if we send out emails, we often don't get responses. So these are very common questions. And I just don't want you to feel, by the way, that you're the only one that has these concerns, because you're not. And again, I talk to my colleagues around the country. It's a difficult problem. Communications, I think, have been the most challenging. By the way, people like Joy every day are at our HICS, and she'll bring these issues up. She will. She'll say, now, let's make sure that we get this out to people. How do we do that? We have a communications group of people, right, Joy?
Yeah.
Who are supposed to help us craft these communications.
Yeah.
I have to say, it doesn't get to everybody, and
No.
it's unfortunate.
Yeah.
So I have a quick question. So
Yeah.
who is going to follow up on this particular, I understand that it may not change anything, but it sounds like Joy said we'll follow up on whether or not there should be notification to like the float.
Yeah.
So
I think it's a couple of discussions with some key people, and I think Augie and Shar and I can all follow up on that.
Yeah.
okay.
To explore,
Valerie, you need
is
to
there
know, you
anything-
should all know that this was discussed this morning. As soon as Joy sent me your concerns, I brought this to the top people at the hospital, because I think these are very important concerns. And I have to tell you, the front lines are critical. Okay, those are the folks on the front lines are critical. And when they have issues, should never, no good leader ignores their front lines. So they were very concerned about it. And I think Joy brought it forward. And I think they're going to want
Val and
follow-up.
Megan and Amber. Yeah.
Well, I mean, Joy
Yeah.
brought it forward to us, and they're going to want follow-up. So, right, Joy?
Yep.
You'll be talking with some of the key players, because you're a bigger shot than I am. You'll be talking to some of the key players today.
Can we ask Amber's very last question in the last 3 minutes?
Yep.
And
So I think we already answered the CFT 6 being considered an option.
yeah, yep, we answered that
So
one.
then the next question after that is with floats, given the fact that they're floating all over the hospital, should they be wearing N95s? Is that basically what you're saying, Amber?
Yeah, like, is there anything that we should be doing? I mean, and I even go back to thinking, like, if I were told before going to Bean 5, hey, there are X amount of patients that tested positive, like, obviously we can't tell the future. We don't know if this is going to be considered an outbreak unit or not, but just so you know, like, would it have changed any of my actions that night? Because I still wore my, my eye protection. I wore my mask. I tried to kind of stay away from my patients, like even when I'm in the room, unless I'm assessing them or giving them meds or whatever the case is. And the answer is really no. I don't think it would have changed anything of how I personally acted. I just know that there are a lot of people that don't wear their eye protection a lot of the times, and maybe that would be a trigger to kind of make them do that or wipe down their station and their computers.
Exactly.
As for floats, going to various units where I feel like just because we're bouncing around all over the place, we do kind of have a higher probability of being on one of these units that has an outbreak. And each unit in the last 2 weeks that I've had an exposure on have all been different units. And so it's like, well, if I were on one specific unit, I would never even know about these other things. And because of that, I feel like we're kind of those like vectors where if one of us is to be sick and don't know it, how detrimental could that be for the institution as a whole? And what can we do to kind of mitigate that?
So the N95s are primarily protection for you. They may offer some protection for people around you, but they're primarily protection for the healthcare worker. I will tell you, Amber, this was brought up today at a 10 o'clock meeting, what we're going to do going forward in terms of outbreaks. We sort of, because of the CFT6, and because of R7, we took a little different approach. And there were some people in our leadership group that thought that maybe N95s might be more protective. We seem to have a very rapidly spreading situation on R7, and we didn't want our employees to be at risk, because then they could spread it further. So the patients were just increasing every single day. Now, again, we're not 100% sure. Sometimes you never figure out where the outbreak came from, but there's a sense that some of us have that this might have actually been spread by patients talking in the hall and, maybe not being masked and roommates and what have you. And it did not seem to be something that was, even though we had a few staff members positive, it didn't look like staff members were spreading it. So that was the reason for the change in policy. We may not change the N9. We may go back to the way we handled all of our outbreaks in the past, which was face shield.
Augie, that makes perfect sense, but at the time, none of us had that information. So when everybody was asking why we were doing it different, we couldn't tell. That was the piece. And it was, I think, no malintent. It was just a breakdown in communication. And so people who were asking those questions just didn't get answers.
Yeah, I agree with you, Joy. And as you know, that came up today, and for folks who, the people that made these decisions said, you know what, we've learned from this.
Yeah.
And we're always learning, nobody does things perfectly, but I get it. And we're sensitive to this. That's the reason why we're doing this, because we're very sensitive to this. We want our frontline people to feel safe. We want them to be safe, not just feel safe, but be safe. So we learned from that. By the way, now, Valerie, did you say you were taking notes, or Megan?
Megan was taking notes, and then I recorded the Zoom. I don't think we're going to be showing the Zoom, but just so we can review it and have.
Oh, absolutely. Yeah, no, that's fine. I think that we do want to bring these points back to people, so that they know. I mean, they already know about the communication piece. That was made extremely clear. Thank Joy. Joy makes it pretty clear.
Well, I really, Amber, first of all, did we answer your questions? Is there anything outstanding? Okay.
None that I can think of right now. And
Well, thank you so much for bringing them forward. I'm sure if you have these questions, and I don't know how many people were at last night's meeting, but there are many people that have these same questions. So maybe we can put the answers out and share those with the team, and that will help. And as Augie pointed out, we learn every day. And I think we learned a couple things from this, that we do need to do communication a little bit better. Shara and Augie, again, I thank you for dropping everything and making this happen today. These are things that you hate to leave hanging out there, right? Till next week when we're on.
You don't do it. I want to address them right away.
Yeah. So thank you all very much, and Val and Megan, for making us aware and getting this going today.
And by the way, this was extremely pleasant compared to what I have to do usually. Amber, seriously, you have no idea. This was very nice.
And we got to enjoy her cat. as
Yeah.
well.
Yeah.
You finally settled down over there.
Well, you all have a great weekend and thanks again.
Thank you.
Thank
Thanks,
you.
everybody.
Thank you.
Thank
Bye.
you.
Bye,
Bye-bye.
Ally.
Bye.
Bye.
Bye, Amber.